Hi everybody, we're just approaching 12 o'clock, so we'll just give people a minute or two just to arrive. I'm sure there'll be plenty of people in back-to-back meetings as usual, or just rushing from the wards or departments. So another minute and then we'll get started. I think we'll make a start just after 12 o'clock. Thank you everybody for joining us this lunchtime. My name's Nick Holding. I'm an improvement manager with the Emergency Care Improvement Support Team, and I'll soon be handing over to the team to share some information with you this afternoon. Just let you know that we are recording the session. We'll share the link in the chat after the sometime later on today or tomorrow, and we'll circulate the link around as well. And the recording of this session will also be on the NHS Midlands future NHS page. Any questions this afternoon, pop them in the chat or raise your hands towards the end. That's fine. If you just want to pop something in the chat, we'll pick that up for you and then put that to the guests later on. So please feel free to put my teeth in. Feel free to interact as much as you want. I'm sure there'll be lots of questions that come out of the two sessions from Richard and from Barry, but for now, I'm going to hand over to Imogen, who's going to kick us off as the chair.
Hi everybody, thank you so much for joining today. There's a great showing of people here, which shows the enthusiasm for the subject. So in July we were set the 100-day discharge challenge to acute trusts, and there were 10 actions within that, one of which was treat delayed discharge as a harm. Certainly in the Midlands, but also I know this invite list is wider than that. We've really thought about what does that mean, and we've spread it wider to, thinking about the harms caused by poor flow in general in the UEC pathway, and what can we do about that. We've held a few learning events. We've had one around data collection and how you kind of measure the harm and then translate that into kind of culture change and change in behaviours and quality improvement initiatives. We've had a second around how do you really get all clinicians on the front line to kind of understand the message about the harms being caused by delayed discharge and poor flow to the patient in front of them, but also all those other patients that are impacted. And then this session is the so what, what are we going to do about this? We've had some great speakers throughout the events, and if you've missed any of them, they are all available, as Nick mentioned, recorded on our Future NHS page, which I'll pop in the chat in a minute. And today we've got some great speakers. I also just wanted to highlight that following from today, there is a community of practice that I'm going to convene. So for anyone that is wanting to do some sort of change project or just wants to hear more about the subject, please do email me. And we now do have the first date in the diary, which I believe is the 2nd of February. So I'm going to pop details about that and the link to that in the chat as well for anyone that wants to join and hear more. The first meeting is going to be half an hour, just as a kind of entry point of what would people want, what would be helpful. So there's nothing set in stone. We can shape it around kind of the wants of those people in that group. So do feel free to join and share your thoughts on that. And at the end, I'm also going to share a link to a Menti survey just to get any more thoughts that you would like to share. So please do take part in that as well. So without further ado, thanks so much to Barry and Richard for joining us. Barry Evans is a geriatrician from Derby and Burton, and Richard Brownhill works for ESIST, is an improvement lead, and is an expert in human factors. I've set them both the unenviable task of trying to explain what they've been doing in this field in a very short amount of time so that we can then open up to discussion. As Nick said, please put your hands up, join in, put stuff in the chat if you want to as well. So Barry, would you mind kicking us off?
By all means. So hi everyone. I'm going to start with a little story about how I got involved in all of this, and then I might show you 1 or 2 slides, but I'm happy to answer any questions on the way through. So I became a consultant the week before lockdown. So I did all my registrar training, lots of things to worry about becoming a consultant, and then COVID hit, and that changed things a lot. So I don't think any geriatrician or most healthcare professionals who are involved in the care of older people are under any illusion of the harms that can come to people when they're in hospital and they don't need to be. And that could be deconditioning, it could be hospital-acquired infection. And the thing which has really changed the game, in my view, is coronavirus. Because not only are you at risk of all the things that were previously there in terms of deconditioning and hospital-acquired infection, but certainly at the beginning of COVID, if you're in hospital, you also had the risk of contracting a potentially fatal virus. I think the bit that's got me most interested in this is that some people absolutely do have to be in hospital. Admission does not equate to failure. And I think if people are in hospital for hard reasons like needing IV antibiotics, oxygen, things like that, then it's not wrong to expose them to that risk. However, if we're keeping people in hospital who no longer need to be there because we can't find the right community package of care for them, we can't find the right place for them to go, then I think it's increasingly difficult to sort of defend these harms from people who are kept in hospital when they no longer need to be. So the project I'm going to tell you about is about our frailty assessment area at the front door of Royal Derby Hospital. It has been built off the back of our frail elderly assessment team, which is a multidisciplinary team, which has previously included pharmacists, nurses and therapists. And the biggest change is that they found there was several people that they thought could turn around and could be cared for somewhere that wasn't the acute hospital, but the clinical decision making at the front door didn't always match what they felt they could do for these people. So what happened is we opened an area, the frailty assessment area, which is predominantly staffed by ACPs and a registrar with consultant support. And the goal of that is from that huge queue in ED waiting to come to the medical admissions unit, we go through it every morning and try and pull people out into a sort of same-day emergency care type area, and we assess them. We get large numbers of them home with the right support they need. But if it transpires that someone comes there and does need admission, it means they've been clerked and they've had an early sort of senior review, which perhaps they wouldn't have got quite so soon waiting in the queue for ED. One of my reflections on doing it is some of what I'm doing down there as a consultant isn't always the medicine, but actually giving the team and giving us all the right and the permission to take appropriate risks to try and get people to the right location. So I'll present you a tiny bit of data which comes from the pilot, if that's okay. In a nutshell, we turn around roughly 28 patients a week. So to put it another way, that's about 1 ward of outliers for people that are in acute trusts. And the majority of these patients were awaiting admission to MAU, where they would have been clerked, senior reviewed, and then a discharge plan made. But we're doing all that at the front door. The data that came from the pilot, which hopefully you can see, had got a couple of quirks in it, which I can explain where I think they come from, but a couple of bits surprised me. So one of those is intuitively, we thought that the patients that we would be turning around would be self-presenting, and actually it transpired the majority who presented had come in by ambulance. We had the biggest impact of people with a frailty score of 5 to 8, so the more severe frailty. And we use a Lorenzo form, which is our IT system, which generates data for the patient set. And in a nutshell, roughly 2/3 of the patients we managed to avoid an MAU admission and plan the discharge from the emergency department rather than bringing them into hospital. One of the other interesting things is we see lots of people who are thought to need medical admission that when they're actually reviewed, they need an alternative speciality. And that has been fractures, it has been small strokes and things like that. So it's not just about the performance at the front door, but also that quality of assessment that gets people to the right place first time. So this is roughly what we've ended up doing. So as you can see, the people we have the biggest impact are the sort of 5 to 8 frailties, which are actually similar to the Chesterfield model and what they've done with their ambulatory area. We managed to get about half of the patients home. There's a slight issue in this chart that some of the patients that were discharged to a ward were discharged to our discharge assessment unit, which I can explain about if you're interested. We struggled to get people to, if, for example, they needed bedded care from ED, partly because of the pressures and the time that it's taking to find appropriate places in the community. So as I asked to be brief, I'll stop there and then I'll happily answer any questions or queries that people want to raise.
Rose?
Yes, thank you very much, Barry. Excellent presentation, excellent work. So couple of queries and a challenge, okay? So, or maybe some additional data as well. So I guess my query and my challenge would be, yes, this is great work that the feed team is doing at the front door, isn't it? So I suppose the challenge would be, just speaking from UHDB to UHDB, it's not just yours and it's not just the team's I suppose work or duty to assess people at the front or queue. You know, it'll be everybody in my view, isn't it? So I suppose where's the in-reach from acute medics and surgeons and everybody else to reach into ED, because each of those will be able to actually make some decisions to kind of take some risks and send some of these patients home. So I guess there is great work and it's a great system, but it's about how we can then try and roll out that principle to other specialties, not just the geriatrician's duty to do that at the front door. You know, there's other people at risk of admission and therefore at risk of deconditioning as well.
I agree. I think the bit which I didn't present is actually to make this work. It's not just about the hospital teams, it's about having really close relationships with the community teams. So we've negotiated various things with community teams to try and get people faster access to the care that they need. So whilst I would love to take all the credit as the feed team and as the geriatrician supporting them, actually a big part of it is this work isn't worth doing unless we've got those relationships with the community teams so that people can move to the right place. And I think some medical specialties do have that. So for example, diabetes have a community team, cardiology is similar, but it is making sure that it's not worth just putting a consultant at the front door and hoping things will improve. You need those community teams and services to be able to refer people onto.
You too. And then just some unvalidated data, if I may image it for everybody. So we've just had some data out, which also went to board, which shows that the sort of average mortality for anybody who's in this staying in the hospital who hasn't got delays is 5.5%. Now I know that's medical and surgical patients, every lumped together and so on. So it's a bit of apples and pears. But in anybody who's got any delay, internal or external, the mortality is twice that, is double. Okay, so you know that is really something that is quite striking. I've never seen it that stark illustrated in any way before, and that should really get us to spring us all into action. Thank you.
I'd be really keen to see a breakdown of that, because I've been quoted that figure before, and what I'd really like to know is it patients who are dying because they're waiting transfer to palliative? Is it patients who are acquiring hospital infections, in which case that's a disaster, or is it something else? And I think it would be really helpful to break down that stat and see what's happening.
Sounds like you guys have got some work to do. You've created some work for yourselves, so you can bring that back to our community of practice and let us know. But I think also I just wanted to bring out the point, Barry, that you'd made about permission, and that a lot of what you do is giving people permission to think about risk differently, because I think that's a lot of what we've been discussing in the last few webinars, and kind of how, when everyone's really exhausted, that we do that. So I think it's kind of interesting that that's been one of your main roles. Ros.
Thanks, Imogen. Thanks, Barry. I'm wondering, not for now, but whether you could share, a bit more detail with, any colleagues that want it, in terms of how you set up, and particularly the makeup of your team. And having tried to set up, or collaboratively set up a service like this before in an acute trust, the limiting factor was access to geriatricians, because you're quite a finite resource. So you might have thought of solutions of that others that others might benefit from as well. So just sharing as much as you can about the setup of the team and the expertise of that team would be really helpful, I think. Thank you.
Yeah, we were lucky in Derby because the MDT already existed. So it was very much all we had to do was bolt on a service, which made things easier. But we have a SOP, we have the costing, so I'm more than happy to share those if it would be helpful.
Barry, we could circulate those and put it on our Future NHS page if you're happy for that to happen. I think the other thing is Barry was very honest with me that one of the other things that sort of facilitated this was some underspend money that you could put to use. And I think at this time of year, if we have got that, and putting it to something that's led to a sustainable service, and Barry, I think another thing that'd be useful is sharing how you've kept that sustainability. Once you had that underspend money, how did you kind of keep the belief in this going forward?
So very much the short-term win from an acute perspective is, even if we can't get these people where they need to be, actually we're pulling 4 to 6 people out of ED twice a day, which is creating capacity in places like majors for that queue at the front door. So that's the very quick win. I think the longer term win is actually making sure that we've got those community relationships right. So we are turning people around, and then we will start to see, I mean, to give some context, Derby's got about 120 outliers at the moment. And if we're discharging 28 people a week who may have otherwise ended up on a ward, at some point we will hopefully start to see some changes in terms of our bed occupancy. I think the challenge is this is all on a background of demand that keeps going up. So it's not always easy to show that cause and effect.
Thanks, Barry. If we get Claire, and then after that, we'll move on to the next speaker, Richard.
Hi, thanks, Barry. Really interesting to hear your stats and figures. Just wondering, sort of, you mentioned around, that the frailty score 91% come in by ambulance, and the severe frailty 5 to 8. Just wondering, sort of, percentage of who of those coming from home and coming from care homes. And sort of wondering then what's going on in the community locally to you around UCR, use of Dockerbo in care homes, and then there's lots of around then how you interlink them with virtual wards, and then potentially what your community teams look like and how they're set up to stop those readmissions and the impact that they may have on readmission.
So there is some data from earlier on regarding readmission from the FEET team before their enhanced team. Because we're relatively new, we don't have that readmission data yet. Right. In terms of community offers, and this is almost another day's discussion, we've got a pilot in Amber Valley where we've got a geriatrician and a GP going around doing that advanced care planning. They've not produced any data yet. They've got lots of qualitative data that the patients like it and the GPs like it. In terms of 91% coming in by ambulance, we've discussed this with the system-wide frailty network, and we think that ambulance might be a surrogate marker for frailty. So, for example, if you travel both ways in an ambulance, it usually means that you're going to some form of care in the community. If you're young and you come with a big heart attack, you'll probably come in by ambulance but go home by another form of transport. So although you might think, or I certainly thought, maybe not everyone thinks it, ambulance is a marker of acuity and these patients are sicker, that's not really what our data shows. And we wonder if actually the mode of transport is actually a surrogate marker for frailty.
Okay, thank you. Thank you. I'm going to have to head off now, so I've got another meeting, but that's great. Thank you.
Thanks, Claire, for joining us. Richard, I'll hand over to you.
I'll get off mute and that'll help, won't it? Okay, I'm just going to share my screen, hopefully. There we go. Good afternoon, everybody. My name's Richard Brownell. I'm a nurse by profession. I work with the emergency care improvement support team. I've got 2 areas of interest, really. One is workforce and one is human factors. The two are interrelated in the sense that if we, in the difficult situation we often have where we're short of workforce, or we describe the utilisation of workforce, if we design our system around the people working within it, we've got a fighting chance of something effective happening. So the onion on the front of this particular presentation may make everybody think, what on earth has that got to do with human factors? I guess if you consider an onion and the layers, some of what we've just heard, for example, about ambulance conveyance of those frail patients, maybe that on a given day, it made sense to somebody to send that person to hospital in an ambulance. So the simplicity of that and the complexity of that is really important to consider within human factors. People have got different views about what human factors is. When I started on my master's journey in human factors, we had to write down what we thought it was. And within about 3 months, I was already in a very different place about what it is. But human factors are here to stay. They're part of the patient safety incident response framework. So our old-fashioned root cause analysis of what went wrong or what can we do to reduce risk has been replaced by a heavily human factors process, really. So I guess it's time to start thinking about how we all get on board. So in this limited time, I just thought I'd pick a few things for us to think about. Ward X has decided that 5 patients are supposed to be being discharged today. And so here we have our 5 patients, and quite typically in most acute hospitals, somebody feels like somebody's been let down, and that might be the experience of the patient, it might be the experience of the staff, the relative. So quite typically we'd look at 4 people went home and 1 didn't, and we rush to focus upon what happened to that 1 individual who we should have been able to get home. And we then start to look at why didn't they go, who was involved, what happened, what did you do wrong? And so we can set up a real dynamic about how we failed to do something. Now, we'd recognise if you were supposed to go home and you didn't, it's an unwanted outcome, but it doesn't necessarily mean that anybody did anything wrong. We're also in a position, because you didn't go home, when we go back to look at what happened, we start to look at that from a position of where you didn't go home. So as a human being thinking about why something didn't happen, we're already a little bit fixated on the fact that somebody in some way failed in their duty, or the patient dynamically changed or something. So hindsight bias is a really important thing to recognise within human factors. So have you considered that all 5 patients might actually get home by chance? Because that is possible. And what we really did is we got 4 people home, my goodness, against a backdrop of all the difficulties we've got. Actually, that's quite an achievement, but we rarely frame it that way, usually because we're desperate to try and empty every single bed and get people home to the right place. So what we need to do is look at what actually happened and be broad in where you look. And the few letters after that there are, what you see is what you go looking for. So actually, when we go looking for things, we look at stuff based on our experience, based on a little bit of knowledge, based on what's gone before, rather than sometimes being a little bit broader. And Eric Holnagel, who's a big honcho, I guess, within the world of human factors, would talk about work as imagined versus work as done. So how often do we look at our actual process, and how often do we blame Dr. X, nurse Y, therapist Z, protocol, whatever? So I think there's something here about, do we go back and actually look at it? Because very rarely are our processes linear. They tend to be quite complex. And the reference just at the bottom there is Eric Holnagel's work on safety 1 to safety 2, which underpins our PSAFE methodology. So just some simplish thinking. We'd very typically go, right, okay, what happened with that patient? Okay, the ward round was running late. They were waiting for a TTO. It's only been written that morning. Transport. So we'd pick out these typical simple things. And this particular patient was, shall we say, waiting for medication. You can see all the different paths, I guess, that can be looked at within that ward setting. But hey, how about we say they were waiting for medication? Let's go and have a look in pharmacy. So we think, because the protocol on the ward says you write the TTO, then it goes to pharmacy check it, then it's ready for ward. And because we've got into a position where we want to get things back quickly, please can you mark your script or your request as urgent if you need it back? So that's what we think is happening. When we go and look at what's actually happening, the TTO goes to pharmacy. It sits in a full tray. That's if you've not got an electronic system, until the staff are available. When it arrives there, all of them are marked urgent, because every ward keeps getting forced by our wider system to hurry up and get people through the system. And pharmacy is so hot, the doors open and every now and again slams shut. And when it slams shut, all the papers, all the scripts end up all over the floor, and somebody tries to put them back in some semblance of order. Then when we've reshuffled it, and unfortunately the patient that was at the top is now at the bottom, we then go through the usual sign-off process, etc., etc. So the kind of tongue-in-cheek message here is that actually some of the issues we go looking for may not even be at that ward level, but do we spend time going to look? And I appreciate the fact that we may not be furnished with time easily to do that. And what I wanted to just kind of share is the last couple of slides, really. One is that we have to remember these things as human beings. We're hardwired to judge. So it's very easy to say what happened to the last patient who didn't go, who, you know, who can we help to understand what's required of them, etc., etc. But actually, if we didn't learn to judge, we wouldn't be very safe at working out whether we could get across the road before the bus hits us. We also can't be objective, because my experience in my career is different to yours. So that doesn't mean you're right, I'm wrong, but it might mean that some things feel more akin to something I understand. There may be other things that are akin to your understanding, and that changes our risk perspective. And I think we don't often spend time when we talk about risks thinking of how we approach risk in terms of how we describe and understand and share commonality. And as a professional, if something happens, so we get a patient who's readmitted, we immediately think we've done something wrong, and therefore it's a marker somehow of competence, and that's a widely recognised and researched piece of information. So again, let's just accept the fact that this happened, then look into it, rather than going to find out who was to blame, so to speak. And we may refer to things in absolutes. So we might hear about mortality data figure X, but actually, what does that mean on its own? I think we'd all recognise that adverse or unwanted outcomes are not great for us or patients, but what we want to do is try and understand that more, to learn from it and build things and recognise that we're not always certain. And finally, I guess the point there, as teams around co-design, if we don't understand, we don't listen. The first thing we should do if we don't understand something is not say to somebody, you should have done, or this could have happened. It's to think about, talk me through why you phone the ambulance. Let's understand that, because I want to be able to be in a position to understand what goes on a little bit more. The sobering thought to leave you with really is that risk is way more about systems thinking. And Sidney Dekker, who talks a lot about patient safety, says the major source of risk lies not with the individuals, but with the system surrounding you. And healthcare staff are the people that actually provide safety in spite of the system conditions. And I suppose it's really important that that tells us that we need to work together. It tells us that we need to be better at designing and thinking about how we put things together. And it's not just all down to us and the decision we made on the day, but that's really important. And I'll stop speaking there.
Thanks so much, Richard. You've stretched our brain, but I think it's so important because we know we should be doing population health management and kind of really co-designing and co-producing solutions with our patients, but sometimes it's hard for us to do that when you get sort of a budget of X to put into practice within 48 hours or something along those lines. And kind of how do we start in systems sort of really going back to what our population needs and what needs to happen to our systems to make this work for the future. And I think some of what you're saying and introducing is really helpful. And we were saying earlier for the community of practice, if we want to explore some of that thinking, in more depth, Richard could run a much longer session to share what we could do. Richard, I just wondered if I could ask an opening question a little bit around, I know that you've used some of this to help with kind of getting SDECs kind of stronger or more robust. Is there a way you can share a little bit about where some of this has helped maybe change a mind, change some culture, get people on board in a different way?
Yeah, so I guess one of the tools that can be quite useful is a tool called SEEPS, which is Systems Engineering in Patient Safety. So you can Google SEEPS and find it. I'll probably be able to find the link any minute now before the end of the session. So using something like SEEPS, it's got different domains within it. It has areas to look at around technology and tools, for instance, around the task you're trying to do. So you can apply it to a really simple task. So you could even say, logging on to a computer. You could apply it to that, because what you need to have is the human capability to do it. You need to perhaps have training. You need to think about if you've got enough brain power to operate a computer. You need to understand the language. So SEEPS is a really useful model. And we used it in a system recently where there was a little bit of animosity, shall we say, strong word, but between emergency department and other teams. So emergency department and SDEC in particular. So ED want to send, SDEC want to, I'm going to say control, because that's the language that was used at the beginning of the session. There's a whole host of reasons why that happens. And in reality, we're human beings. So if I'm overloaded and feel like I'm not, for some reason, helping pull patients through and see them, that has an impact on me. Equally, I might think I'm doing everything within my gift, and nobody's judging anybody on that. What we want to do instead is understand what makes that happen. What are your risks? What are your concerns? So using something like SEEPs with a really open and honest conversation uses a template to help us all to think about the design of that access or design of that process, rather than saying, you know, there's an obvious reason why I might not take low risk chest pain, but actually John, when he does SDEC, takes low risk chest pain. So we can start to open up the dialogue about, well, so are we purposing our SDEC to take low risk chest pain? And we can start to design and make some principles that say, this is how we want to go on and do stuff. So using a model like that is really helpful. And if you want some help with it, your patient safety specialists in hospital now under PSERF should all be using SEEPs and human factors techniques. So they will welcome the practice as much as you will welcome the benefit of somebody applying that. So SEEPs is quite a good model for looking at systems thinking.
I'm immediately thinking, Richard, of applying it. We're looking, Fiona and I and some others, at what to do with people that are considered like a long lie in the community. And I think that a lot of your thinking might be helpful in terms of trying to build consensus amongst many people as to what that is and what we do with it. So I can think how to apply it already, Richard. So I hope others are beginning to get some of the journey. And I've put some of the links in the chat that hopefully give a bit more of an introduction and a bit of an interest. Do you have any other questions for Richard or at all? The other thing I wanted to use this time for was just to recap a little bit on the resources that are available on the Future NHS page. So for those of you that are wanting to kind of just build that momentum, there are posters that we've created. We are also working on the video, which is still not quite there, but is nearly there. And I'm going to just show you one shot from it to kind of show the concepts and ideas of how that's going to come across. There's also some workshops that have been put on there. So, you know, I guess it's giving an opportunity for people that want to spend 30 seconds versus an hour on trying to introduce this subject. There are like pick a mix of resources up there. And I think it's thinking about how you do it in a targeted way, i.e. it might work well to put the posters up the same week you think about running a workshop on, and it can be ward level. You could do it in a, you know, in a gram round, do it bigger, or you could do however you want to reach it. And also just to say that we'd love to support that. So if there's anything NHSE can do or ESIS can do, please do reach out to us and then we can talk about that. I will just show you this on the screen so you see the idea of it if my sharing works. Bear with me 2 seconds. I hope you can now see, so one of the shots that comes out of the video, we introduced some characters, including Sarah, who's there in the picture, but then trying to just help clinicians see what they might do differently. We're trying to do it in a very like non-threatening way, bearing in mind the state of the workforce at the moment, but just kind of help nudge people a little bit just to think slightly differently. And I think the last webinar or learning event, whatever we want to call it, was quite helpful with John Day talking about do we really need that extra blood test and that kind of thing. So it's all aligned. If there's anything else you think we can do, please do put it on the Mentee survey, which should work. Every learning event I've said it should work. This time I really do think it will work after various tweaks. Thank you so much for joining us for the 3 webinars, and Nick for supporting us from ESIS. It will be recorded, today's event, yeah, do reach out to us in the future if there's anything else we can do to help. Fiona.
If people want to be a part of the community practice taking this forward, please write your name in the chat and we'll contact you. This isn't the end, this is just the beginning.
Thanks so much, Fiona. And I also did put the link to the first session, which is the sort of introductory session, which is on the 2nd of February at 12 o'clock. So I've put the Teams link, but if you want the invite do email us, because that will really help us kind of keep linking in with you. And at the moment, this is the last of the learning events, but if again, we'll look at that mentee survey, so that if there is sort of requests for other things, we'll do more. If you found these useful, it's hard for us to judge how useful they are and what else we can do to help if we don't get that feedback. So please do feedback to us. And if you can't be bothered to do mentee, which I know sometimes is a bit hard, anything you want to write in the chat, we won't take anything personally, just go out there. But the mentee is anonymous, so it gives you that ability to do things anonymously if you'd rather not just write it in the chat. But please do go for it, because we just want to help. So thank you so much. We will close today's session.
Thank you.